Hi, hello friends, welcome back to channel. So as you know, we conducted a grand medicine quiz for NEET. Almost 300 participants participated. Thanks for that. And among them, we selected the top 50 rankers. This is the rank list of those members. Congratulations to all of them. So here in this upcoming sessions of videos, we'll be discussing the solution part of the 50 question quiz in a subject-wise manner. Okay, first we'll start with CNS today. We'll decode all the answers of those quiz questions. Then we will analyze some high yield points for NEET, which you should never forget in the aspect of NEET clinical questions. Okay. Yeah, the first question is, a 45-year-old patient came with sudden onset right-sided upper and lower limb weakness since 2 hours. NEET head was done, which is given below. PP is 200 by 100. What to do next? Next they have asked. And they have given the CT scan image. Followed by options are, go for thrombolysis with IV alteplase as he is within window period. Next is control BP first by giving labetalol, then try thrombolysis. C. Don't thrombolyze as CT shows bleed. D. Try for mechanical thrombectomy in this patient. So if you see in this question, there are multiple strategies involved to decode this answer. For this, you should know the management protocol of any ischemic stroke in detail. Okay, this will help you in NEET also. First thing, when to do a CT scan for a patient suspected of stroke? The answer is within 20 minutes of arrival to the hospital, you should do a CT scan. In the CT scan, why are you doing it? Just to rule out hemorrhage. We can't find the ischemic infarcts and all in this CT scan in most of the patients. Okay, so by doing CT scan in a hemorrhagic patient, what will happen? See, these are the whitish areas, radio opaque areas. These represent the hemorrhage with surrounding blackish area, the areas which represent the edema. So hemorrhage with edema, this we should rule out. So only we are doing the CT scan initially for any suspected stroke patient. Then in this question, if you see, there is no whitish blood oozing out and all. So it's not hemorrhage. First point. Next, how to manage a acute ischemic stroke? First see this is actually a medical emergency. So your first thing should be ABC, airway, breathing, circulation. Stabilize the airway. If GCS is very low, you can go for intubation also, breathing. Okay, and circulation you should ensure whether the patient is in hypotension or BP management is the next thing. Next, as we told, BP management and dextrose management are integral part in case of stroke. Then comes your CT scan. CT scan you are going to do within 20 minutes. Then you are going to decide whether it's hemorrhage. Then you are going to manage as hemorrhagic stroke. If it is ischemia, then you are going to depend on the time of onset. From what time the symptoms are manifested. We are going to manage with this kind of pathways. Okay. First, let me deal with the dextrose control or glucose control in stroke patients. What should be your target? Your target should be 140 to 180 milligram per deciliter, your blood glucose. If it is less than 60, yes, you should treat with D25 dextrose. Or if it is more than 180 also you should treat, because hyperglycemia also impairs the recanalization and penumbra resolution. All those hyperglycemia inhibits. So hyperglycemia is must be treated in acute ischemic stroke if it is more than 180. Next comes BP control, which is the most integral part. First, if you see you are checking whether the patient is eligible for thrombolysis or not, if he is within the window period or not. Okay, window period means for stroke 4.5 hours. Okay, yeah, he is eligible for thrombolysis. Then your BP control should be the next part. Your BP should be controlled less than 185 bar 110. This should be your BP control. Okay, 185 bar 110 should be your control. So, or else if it is more than 185, you are going to control it by giving some labetalol, which is a alpha plus beta blocker, which is used in hypertensive emergencies like these kind of things. Or you can also go for nicardipine. You can go for these to control the blood pressure to bring it less than 185 110 so that you can proceed for thrombolysis. Okay, yeah, thrombolysis, what is the agent of choice? All RTPAs can be used, but the preferred agent in stroke is alteplase. You see the indications and contraindications of thrombolysis. You are finding that the patient is out of window period or is contraindicated for thrombolysis. Then what are you going to do? Then his BP can be till 220 bar 110. Till 220 his BP can be there. It's normal only. Okay, so till 220 it can be there if the patient is not taken for thrombolysis. This is regarding BP control in acute ischemic stroke. Next come to management of stroke, acute ischemic stroke. So as I told, time since onset of symptoms. Some might tell that the patient was talking well yesterday night and today morning he is found to be having this deficit. So in that case, you should take the time when the patient was normal, last seen normal, that you should take. So that will be become more than 7 hours, 6 hours if the patient has slept. Okay, so that you should keep in mind. Next is, you are finding the time of onset to be less than 4.5 hours. Then he is obviously within the window period. Here, manage the BP control and check for the indications and contraindications of thrombolysis. If it is indicated, yes, go for thrombolysis immediately with IV alteplase. You are finding it to be himself a contraindication for thrombolysis. Then what you can do? Next step is CT angiography. Why to do CT angiography? So that you can plan for mechanical thrombectomy in that patients. The patient might have some contraindication for thrombolysis, but mechanical thrombectomy we can do. Okay, so go for CT angio, and in CT angio, if you find that he is a candidate for mechanical thrombectomy, go do the mechanical thrombectomy. Okay, yes, this segment is over. Next, what if the patient presents between 4.5 hours to 24 hours, 1 day? Here also, still the patient is eligible for mechanical thrombectomy in specific circumstances. Okay, so here also you should be doing CT angiography, check whether he is eligible for thrombectomy or not. If eligible, yes, you can go do mechanical thrombectomy. If you find it is not eligible for thrombectomy, then you can go give just antiplatelet drugs, antithrombotic agents. Okay, then what if the patient presents more than 1 day, more than 24 hours? Here though no other choice, just to give antithrombotic agents and do physiotherapy and all the physiotherapy exercises just to till the power and tone recovers. Okay. Next thing what you should know is the indications and contraindications of thrombolysis. So indications, as you know, main important thing is the age should be more than 18 years. In less than 18 years, you should never thrombolyze. Okay, more than 18 years, and if he is within the window period, 4.5 hours, next clinical suspicion of acute ischemic stroke, here you can go for thrombolysis. And contraindications, most important. See, when the patient had a history of subarachnoid hemorrhage, intracerebral hemorrhage, any time in his life, is contraindicated for thrombolysis for life. Never thrombolyze the patient. If the patient have any head injury in the recent 3 months, then you should not thrombolyze. Or any neurosurgery in the last 3 months, should not thrombolyze. Any ischemic stroke in the last 3 months, then also never thrombolize, because if you thrombolize, that might go into, that ischemia will go into hemorrhagic transformation. So you should never thrombolize in the last 3 months. Same thing, GAT, active GI malignancy, active GI bleed, never thrombolize. And if any GI peptic ulcer in the recent 21 days, never thrombolize. Okay. Next, what you should know is heart. With respect to active infective endocarditis, never thrombolize, because infective endocarditis might have thrown vegetation and it will block the artery, resulting in ischemic stroke. But if you thrombolize, that area is already superseded by infection, so it might easily go into hemorrhagic transformation. So never thrombolize in active infective endocarditis. As well as acute aortic dissection, there also you should never thrombolize. If you thrombolize, so what will happen? That false lumen in the aortic dissection will be blocked by the blood clot. If you will thrombolize, and it will just propagate the aortic dissection to happen further. So aortic dissection, never thrombolize. So all these are the contraindications you must know. Okay, and also in other coagulopathies, bleeding disorders, all those things also. Okay, yeah, this is the list you should be remembering. Yeah. Next question. A 60-year-old female diagnosed to have lateral medullary syndrome will have all the following features except A. Vertigo, nystagmus. B. Loss of taste. C. Contralateral loss of pain and numbness if in half of face. Then D. Ipsilateral Horner syndrome. So for this, any brainstem syndromes, if they ask in exam, how to localize? Clues. First, brainstem syndromes. Always, it's a must to have some cranial nerve involvement. If it is 3-4, localize to the midbrain. 5 is there, then it might involve any part of the brainstem. That you should know. 5 can involve any part of the brainstem. Midbrain, pons, medulla. Okay. Then 6-7 is there, then it's pontomedullary junction. Or 8 to 12 can be involved in medulla oblongata lesions. Okay. Yeah. Next. Then what lesions can be there? Cerebellum can be affected. Since it is in the sides, it can be affected. And sensory tracts can be involved, motor tracts can be involved, as well as sympathetic trunk can be involved. These are the characteristic feature of brainstem syndromes. So here we will discuss these two in detail. First, medulla. We'll just draw medulla so that it will be very easy to decode the clinical features. First, if you draw medulla, the medial portion, this bulbs, contain the corticospinal tract, which are the motor tracts. Okay, yeah. If you go behind and see, there are this trigeminal fibers. In the one half of the face, pain and temperature is carried by this fibers in the medulla. It will go up in the pons, then only they will decussate. They have not decussated till now. You should remember this. Okay, pain and temperature in one half of the face carried by the spinothalamic tract of the trigeminal ganglion. Okay, next is this red portion, which is a sympathetic tract coming from the hypothalamus, sympathetic ganglion. So from there it will come descend down and will go to the sympathetic ganglions. Okay, yeah, they haven't crossed. Yeah. Next, you see the medial lemniscus. The fibers, as you know, these are the dorsal column fibers which have decussated in the lower medulla. They have crossed and they are ascending up in the upper part of the medulla. So already crossed fibers of the medial lemniscus are ascending, okay, in this part of the medulla. Okay, medial lemniscus. Next if you see the sides which communicate with the cerebellum, cerebellar peduncle, inferior cerebellar peduncles will be there, communicating the cerebellum. And then if you see 8th nucleus, vestibular nucleus, you would have heard, okay, concerned with balance as well as this vestibule as well as cochlear component, both are attached to this 8th nucleus. Next, if you see 9th and 10th nerve nucleus, the nucleus tractus solitarius. You can remember symbolically like 4 components as I drew there. First component is the tongue, taste fibers. Okay, next is the in between component, which is the baroreceptors for the heart, as well as pulmonary cough receptors, lungs. Then last is GI tract, peristalsis, also controlled by this nucleus tractus solitarius. So 9th and 10th nerve will be governing this. Next, if you see the dorsal nucleus of vagus, which is the motor nucleus of vagus, all the motor system functions. Next, medial most is the 12th nerve nucleus, which will be concerned with the tongue functions, motor functions for the tongue. Okay, so this is the cranial nerve nuclei. Now let's see what happens in this Wallenberg syndrome. Wallenberg syndrome is caused due to this lateral segment of medulla is becoming ischemic, infarct. Why is it happening? Mostly would have learnt it as pica syndrome, posterior inferior cerebellar artery syndrome, pica. But the most common artery involved is vertebral artery followed by pica. This you should know. Next, clinical features, if you see the lateral segment is completely infarcted. So one by one, start telling with me. First, what is happening? The trigeminal spinothalamic tract, which was carrying the pain and temperature from one half of the face, that is affected. So it has not crossed in this segment. So ipsilateral loss of pain and numbness in one half of the face. Yes or no? Yes. Next, sympathetic tract is affected, ipsilateral. So in that segment, Horner's syndrome will manifest. Horner's syndrome manifested by meiosis, enophthalmos, ptosis, and lack of anhydrosis. Then loss of ciliospinal reflex. This pented will be seen. Next, if you take next nerve is 8th nerve, cranial nerve nucleus. So vertigo, tinnitus, all these things can manifest. Nystagmus. Then if cerebellum, ataxia, definitely. Next, 9th, 10th nerve involvement will cause dysphonia, dysarthria, okay, and dysphagia. All these can manifest. And gag reflex will be lost. All those will be there. Okay, yeah. So this will be seen. Next, so medial lemniscus, if it is affected, then contralateral loss of sensations in one half of the body will be seen. Okay, so if you closely watch Wallenberg syndrome, it is nothing but they are sensory loss only. No motor deficit will be seen in Wallenberg syndrome. Next, loss of taste will be seen because nucleus tractus solitarius is affected. So loss of taste will be definitely seen. Okay, so all are the clinical features of Wallenberg syndrome. Now in the same medulla section, we will learn medial medullary syndrome also. Okay, so here what happens is medial most segment of medulla will be infarcted. So the 12th nerve nucleus is affected, and this motor part, this bulb consisting of corticospinal tract will be affected. So that will cause contralateral hemiplegia of the arms and legs with tongue, loss of power in the tongue muscles. Okay, ipsilaterally. Yeah. So the next question is the features seen in the disorder with the brain biopsy given below is: option A, slowness of movement is seen in this disease and tone is increased in flexors as well as extensors. B, phenomenon of anticipation is seen in the generations of the people characterizing this disease. C, short-term memory is affected. And D, C, commonly in cannibals. Okay, so yeah, come to the brain biopsy image here. You can see some pinkish material deposits in the brain. So obviously they are amyloid deposits, A beta 42 amyloid. Remember that, it's very important. And if you can find the blackish deposits also. They are nothing but hyperphosphorylated tau protein. Alzheimer's disease is a taupathy, meaning these tau proteins are normal microtubule proteins. Okay, they will be present within the cell, and these proteins will be accumulated in excess and phosphorylated in excess, leading to formation of this hyperphosphorylated tau proteins, which we call it as neurofibrillary tangles. Okay, these are neurofibrillary tangles. And the A beta 42, which are the extracellular amyloid depositions. Okay, we also call it as amyloid plaques depositions. So this is happening. See the causes of the Alzheimer's. First, genetic causes. In chromosome 14, there is a gene called presenilin 1. Presenilin 1 meaning early onset Alzheimer's, and the most severe form of Alzheimer's will be seen with this mutation. Next is presenilin 2, which is present on chromosome 1, also a cause. Next, ApoE gene polymorphism. ApoE4 gene carries maximum risk. Actually, there is a biological marker. It is actually a biological marker denoting the risk of progression to Alzheimer's disease. Okay, this is the apolipoprotein, which is involved in cholesterol transport. This is involved in Alzheimer's disease, E4 part. Yeah. Next, now we will see the sequential disability seen in Alzheimer's disease. What happens in Alzheimer's is these plaques and fibrillary tangles start to accumulate in the brain, first in the medial temporal lobe. Medial temporal lobe is the source of those hippocampus and all those entorhinal cortex. All those are the areas involved in the generation of short-term memories. This is affected. Okay, so earliest and most severe affected area is medial temporal lobe. So the patient will have short-term memory loss first. Next, lateral temporal lobe. As we know, in the temporal lobe, the vernix area, all those areas are there. So in these patients, this language comprehension will be affected. They won't take, half of the time they can't understand the language properly because this vernix area is getting affected there. Next, what happens is the area, nucleus of main heart. This is the heart of acetylcholine brain. This secretes acetylcholine like anything. Okay, the nucleus of main heart, which will present in the brainstem, it sprays acetylcholine to the frontal areas of the brain. This acetylcholine reaching the frontal areas makes us very active and alert. The nucleus of main heart is degenerated here in Alzheimer's. So what will happen automatically? The alertness level will reduce. The patient won't be alert that much. The patient won't be aware to the surroundings. He will be not involved in any activities, social behavioral abnormalities will be seen. Okay, can you understand how to correlate it? Next, if you see, you can slowly go into the parietal areas will be involved. There, what will happen then? Apraxias, the learned motor movements which the patient was doing previously, he can't do it now. Like unbuttoning a shirt, all these things he can't do it now. And main thing is this parietal lobe is involved in geometrical association. Meaning, in your brain itself, you can map where is my house, how to go to reach my house. All these mappings done in the parietal lobe of the brain. So this lobe is degenerated in Alzheimer's. So that will contribute to this geometric task they won't be able to do. They won't be able to identify their own home location. They will be lost. They will tell, I felt lost in my own locality itself. Okay, those features will be there. Then at the last, if you see, frontal lobe will be affected. If frontal lobe is affected at the end stage, patient can't do anything. Like they call it as akinetic mutism, meaning no movement at all, no talking at all. Mute, akinetic. The last psychiatric syndrome you should remember, which is Capgras syndrome. Okay, meaning even his own caretaker, he will see it to be an imposter, stranger. Okay, Capgras syndrome is also seen in the ultimate end stages of Alzheimer's disease. Okay, that's it for Alzheimer's. Next comes his brother, Parkinsonism. So here what all you should remember with respect to NEET. Most common cause is idiopathic. Idiopathic means due to normal degeneration process happening in the old age. Okay, idiopathic Parkinson's we call it as Parkinson's or paralytic adjuncts, paralysis adjuncts. Okay, yeah. Most common secondary cause of Parkinson's is nothing but the use of antipsychotics, which will have a dopa blocking effect. Okay. Next is the environmental agents which can cause Parkinson's. One is your manganese mineral causing Parkinson's. You should remember. Next, MPTP, a toxic compounds you would have read, but this comes mostly from the heroin addicts. Okay, MPTP will be generated, which will cause Parkinson's. You should be remembering that. Then, carbon monoxide poisoning can also cause Parkinson's. You would have read in FM. Okay, remember these. Then, genetic cause of Parkinson's. Two causes you should remember. If it is late, early onset, less than 40 years, cause will be PARK gene. If it is more than 40 years, LRRK gene. Okay, these are the causes of Parkinson's. Then in features, what you should know is, apart from hypokinesia, bradykinesias, the gait you should know properly. How is the gait? Is ignition will be very low, failing to start to walk itself, because basal ganglia is the initiator of movement. You can't initiate walking, so reduced ignition will be there, and once you push him, he will start walking. But how will he walk? He can't take some big steps, some small steps, that he will walk slowly. Okay, and he can't turn suddenly, or he can't brake suddenly. He will be slowly walking with slow steps, and his arm swings won't be there, because for arm swings also he should initiate a movement. Basal ganglia is affected, initiation of movement affected, so reduced arm swings characterizing this festooned gait. Okay, next is resting tremors. You should know this important point. It's the most common as well as earliest finding is resting tremors. Okay, resting tremors, if you see, it will start initially in the upper limb, where we call it as pill rolling tremors. Next, it will slowly progress into lower limb too, and the frequency you should know, it is 4 to 6 hertz. Yeah. Next is your lead pipe rigidity. Tone increase both in flexors as well as extensors, characterizing the lead pipe rigidity. And best, it is characterized by which joint? It is the wrist joint. You should remember this. Wrist joint is the best joint to examine for lead pipe rigidity. Okay, yeah. Next, treatment, you go read separately in pharmacology, focus much on there, because most of the questions are asked from the anti-Parkinsonism drugs. Okay, focus there. Then regarding to medicine, if you see, this on-off phenomenon is a important area to focus. If you see here, actually there is two thresholds. One is the level where the drug starts exerting its effect. Like the Parkinsonism patient will be off, he won't be doing any action, akinesia will be there. When you give the drug, when the drug reaches this therapeutic level, he will start doing actions. But if the drug reaches the toxic level, then he will start doing too much of overactions. Like extra movements start to manifest, like extra pyramidal movements start to manifest. So you should maintain within this narrow window. Okay. At the same time, the patient should be on continuously. Okay. So when the patient starts doing actions after giving your drug, that is on. When the drug effects falls below the therapeutic range, he will be off again. So your aim is the patient should be continuously in the normal therapeutic range. So for that, what you can do is two options you can do. One is give small multiple frequent dosings so that your range always remains in the therapeutic range as given in this picture. Okay, or you can directly go give some dopamine agonists like apomorphine. Only emergency in Parkinsonism is this off effect, on-off phenomenon. There you should be giving apomorphine. Okay, you should never forget. Yeah. Next question. A 25-year-old patient complaining of sharp lancinating pain over the bilateral mandibular regions of more than 1,000 episodes in a day. He is able to chew well, but he experiences these episodes whenever he does shaving of his beards. Possible diagnosis is A. Thalamic pain syndrome, B. Pontine hemorrhage, C. Multiple sclerosis, D. Anterior limb of internal capsule infarct. I know some 70% of the people have chosen thalamic pain syndrome because of some nostalgia with your INI-CET, I think. But read this question properly. Let's deal it in a step-by manner. See, this is nothing but trigeminal neuralgia happening here. First, let's know in detail of trigeminal neuralgia, what's happening there, so that you will be able to decode this question. First, in trigeminal neuralgia, as we know, it's a neuralgia, pain. So I will be describing with the R Socrates mnemonic. Site. Where is site of the pain? See, it's a trigeminal neuralgia. Obviously, it should start with 5-3. Mandibular division, which is the most commonly involved, followed by maxillary division, followed by ophthalmic division, which is rarely involved. So it progresses like this. Okay. Yeah. Then, how is the onset of pain? Can you decide when it will come? No. It will come suddenly. Onset will be sudden, lancinating, electric shock like pain will be coming, and it will last only for few seconds to minutes. Bas. Okay, only 1 minute it will last. It will be like current coming here. Few seconds, sudden onset, lancinating, like with killing with a knife. Okay, like that kind of a pain, lasting for few seconds to minutes. Okay. Next. So, triggering exaggerated by movement allodynia or tactile allodynia. What is the meaning of this? This will explain the entire process of trigeminal neuralgia. So let's see what is happening in trigeminal neuralgia. Why is this pain coming here? First, if you see, this is the brainstem. Okay, the vertebral artery is coming, it forms basilar artery and divides into posterior cerebral artery behind. And then here you can see this trigeminal ganglion. In between the pons is the main region for trigeminal ganglion to form. There it is forming and is dividing into 3 portions. Okay. Here, if you see the superior cerebellar artery in old age people due to atherosclerosis, what happens is this thickened atherosclerotic superior cerebellar artery will compress this fibers, nerve fibers of the trigeminal ganglia. Okay, though that will block the conduction of some fibers in trigeminal neurons. Okay, this will happen usually unilaterally in old aged people with atherosclerosis. Unilaterally, it will be compressing. This will contribute to unilateral facial pain. Everything will be happening. If at all, if bilateral happens, or if it is happening in a young age, your suspicion should be more towards multiple sclerosis, because demyelination, if it occurs at one area, you can suspect of all these kind of things. But if it is occurring in the multiple areas, that too in a young individual, should suspect of multiple sclerosis. Okay, yeah, because it's a demyelinating disorder of the central nervous system. Next, so why is this pain happening? Let's see this characteristic feature. So if you see here, fifth nerve, as you know, A alpha, A beta, A delta and C fibers. All fibers are present in the fifth nerve. A alpha, A beta for those proprioception, all for those sensations it will be going on. Then A delta for this fast pain and C fibers for the slow pain. It will be usually carrying. Here what happens in trigeminal neuralgia is due to compression by the superior cerebral artery or due to demyelination affects the maximally myelinated areas, which are the A alpha as well as A beta. So if these are affected, meaning they are irritated. So whenever their neurons are fired, whenever their neurons are stimulated by some actions like proprioception, stimulated by movement of your jaw. You are moving your jaw, that will stimulate your proprioceptive fibers. A beta fibers will be stimulated, A alpha, all those, and already they are hyper irritable there. What they will do is, since they are hyper irritable, they will spill their action potentials to the nearby neuron, which is nothing but the fast pain fibers. So whenever you do any movement, or whenever you touch, fine touch, proprioception, all these sensations will be carried to these A alpha and A beta fibers, which, as they are hyper irritable now, they will spill their action potentials to the A delta fibers, which are the fast pain. So thus fast pain is perceived by those individual. Sharp, lancinating, sudden onset fast pain lasting only for a few seconds to minutes, only because of this impulse spilling out. Okay, now you understood. So what is the problem here? Now I'll explain the treatment also easily. Now, so what is the problem here? Excess action potential generated. So to block the action potentials, you need a sodium channel blocker. Yes or no? Yeah. It is nothing but our carbamazepine, oxcarbamazepine, phenytoin, all these drugs can be tried. Now do you know this is the neuralgic pain, neuropathic pain. So here you can't be going and giving paracetamol or NSAIDs to control this pain. This can be controlled only if you control the nerve discharges. Okay, yeah. Next is, last you can also go for surgical treatment like alcohol injection they will do, and even gamma laser radiation that they have discovered for treatment of trigeminal neuralgia. Okay, hope you enjoyed all the discussion of CNS part. We'll be following with rheumat, and slowly one by one topic will be decoding in subsequent sessions. Okay, and congratulations to all those who participated and those who secured top 50 ranks. All the best for you people for getting max scores in NEET. Thank you.